Okay, so this chapter that we're going to be covering is nuclear medicine and PET. So NM is the abbreviation for nuclear medicine, and PET is the abbreviation for positron emission tomography. So we use nuclear medicine and PET for diagnostic and therapeutic. What is nuclear medicine? So it's a medical specialty that uses radioactive material to both diagnose and treat diseases of the body. So nuclear medicine is imaging, documents, organ, function, and structure. So we can look at the actual function of the organ along with the structure with using nuclear medicine and radioactive isotopes. So the principles, we use a radiopharmaceutical. There's two components. There's a radionuclide and a pharmaceutical that's combined. So the pharmaceutical is selected based on the role in the target organ or the physiological function, where the radionuclide is tagged to that radiopharmaceutical. So these are the radionuclides that are stable, so in the shaded boxes. So this is what you found on the periodic chart. So physical principles. Radiopharmaceuticals are administered to the patient, and then the target organ is localized by the radiation emission from it, and is detected by a gamma camera or other kind of radiation accepting instruments. So technetium-99 is the most commonly used radionuclide in nuclear medicine. So here you can see there's a lead shield here, and the technologist is drawing up some isotopes here behind the lead shield so that they're not exposed. And they will administer into the blood. Typically, it can be inhaled or ingested to look at different areas of the body. So, preferred radiopharmaceutical characteristics. So they're easily produced and readily available, and that's changing with the nuclear power plants. They're not as easily found, or there are shortages that come and go. They're low cost, and it's the lowest possible radiation dose to the patient. The primary photon energy is between 100 and 400 keV. The half-life is greater than the injection prep time typically. That's not true in all cases. So the effective half-life is longer than the exam time, which is good, and the suitable chemical forms for rapid localization and different uptake in the structures to be detected than the surrounding tissues. So it's targeted. Low toxicity in the chemical form and is administered to the patient, and it's really stable within the body. Oops. So nuclear medicine procedures may be diagnostic, which are tests for body function; therapeutic, which we use radiation to treat the diseases like thyroid cancer. We'll go ahead and inject and have the thyroid treated. Radionuclide therapy is used to treatment of both benign disease, so like hyperthyroidism and arthritis, and malignant disease such as the thyroid and hepatocellular carcinoma. Radiopharmaceuticals. So there's the diagnostic radiopharmaceuticals. They must deliver the minimum possible radiation dose to the patient while still obtaining the required diagnostic information, where therapy radiopharmaceuticals, it's a mouthful, must deliver the maximum radiation dose to the diseased organ or tumor while mimicking the radiation dose to a non-target, minimizing the radiation dose to the non-target tissue such as bone marrow to ensure minimum radiation of other parts of the body. So, Radiopharmaceutical Administration. So depending on the study and the pharmaceutical, it can be injected intravenously or occasionally arterially. I've never seen it injected arterially, but I suppose it could. Inhaled gas or aerosol, or ingested as a liquid or a solid meal. So, what do we use to do this? It's a gamma camera. It locates, measures, and amplifies gamma rays emitted from the patient. It can be single head, dual head, or triple head. So the dual head is the most common. Triple head is used primarily in SPECT, which we're going to talk about. Computers analyze and display data from the gamma cameras. So with the gamma camera, we have a collimator, there's crystal and light pipes, and there's detector electronics. So the collimator is located on the detector face at the photon entrance to the camera. The function is to separate gamma rays and keep scatter rays from entering the scintillation crystals, and is composed of lead or other material with a high atomic number, so it can't be penetrated. The crystals in the light pipes. Crystals commonly composed of cesium iodide with thallium trace added to increase light production. Crystal compositions can stop most gamma rays emitted from the nuclear medicine radiopharmaceuticals. The thicker the crystals, the better for imaging radiopharmaceuticals with higher energy. So it also gives decreased resolution though. Thinner crystals, you have better resolution, but can't image with the higher keV photons. So the light pipes, they're discs of optically transparent materials, functions to help direct photons from the crystal into photomultiplier tubes, and may be used to attach crystals to the photomultipliers. So the PMTs detect and convert light from crystals to electronic signal and amplify signal by as much as 10 to the 7th. So PMT arrays is attached to the back of the crystal or lead pipe, and the typical gamma camera detector head contains 80 to 100 PMTs. So Detector Electronics, the PMTs perform a series of processing steps on the signals, including location of the X and Y axis of the original photon and its amplitude or energy, which is the Z. Pulse height analyzer eliminates Z signals that are not within a desired preset energy range for a particular radionuclei. So it reduces scattered lower energy or unwanted photons, which we call noise, that degrade image resolution. The processed data are transmitted to the displayed system. So gamma cameras. Originally, they were single head systems. Newer have up to 3 heads, what we usually use for SPECT imaging. They have multi-crystal gamma cameras, so they utilize an array of crystals that are coupled to positron positive sensitive PMTs, which is PS PMTs or photodiodes. So the components here. The efficiency of the detection increases with the increased crystal thickness or decreases with the increasing photons, so energy. So you can see you have your collimator, you have your detector crystal, you have your photomultiplier tube array here, and your positron logistics circuits. And then you have your detector cover here, and then the computer. So here's another picture. This is typical gamma camera, which includes complex computers, electronic, mechanical components for acquiring, processing, displaying, and analyzing nuclear medicine images. So you have the patient here who's emitting gamma radiation. It is picked up. The collimator controls how much is picked up. You have your cesium, iodine, thallium activated crystals. And then you go into your light pipes that go to your photomultiplier tubes, and then you can see here pulse height analysis, amplifier, etc. And then your electronics, and then it's converted to a image. Scintillation cameras or gamma cameras, first developed by Geiger in 1958. I like his last name. Still used in modern gamma cameras. You can see here this is dual head, so there's two heads on either side. So this is your dual head camera. This is the most common that you'll see at the hospitals and outpatient centers. So the principle of operation of a scintillation detector. So a radionuclei, we're going to go through this again, emits discrete energy photons which can either be totally absorbed, partially absorbed, or completely missed by the scintillation detector. If the gamma ray is absorbed, the scintillation detector converts the energy of the photon into a flash. A flash of light is converted into an electrical pulse, which is amplified in the system and analyzed. Depending on the energy initially absorbed and depending on how the operator sets up the scintillation detector, the photon is either counted or rejected. So that's how basically it happens. Radiation safety is really big in nuclear medicine. So special safety precautions are required, but most radionuclides continuously emit radiation after administration. So preparation area in nuclear pharmacy contains isolated ventilation, protective lead or glass shielding for vials and syringes, and they'll actually put the vial or syringe in lead-lined boxes with lead-lined syringes. Gloves and lead syringe shields required during handling and administration to reduce exposure to hands during administration. So there's little lead shields that go on the syringes, and there's also a box that we carry them in. So spills must be properly contained and cleaned. Gloves are required because the agent can be absorbed through the skin, causing unnecessary exposure to the operator. And technologists and nuclear pharmacists must wear radiation monitoring devices on their hands and bodies to measure the dose. So they always have a ring detector on. So this is what a hot lab looks like, nothing fancy. And they would draw up all their radioisotopes underneath this little lead glass. Geiger counters, we actually have both of these. So we have the newer version of this one. I think we have two of them, and we just purchased this one here. So these are Geiger counters, and they measure the amount of radiation giving off in an area. So you'll see the nuclear medicine techs walking through the hallways. They'll check their lab. They're going to make sure that it's safe and that there's no drips or anything on the counters or the floors. Okay, so here is an example where they're going to draw up the isotopes. You can see the little covers there. The gloves, yes, you knew wear gloves. Some wear lead-lined gloves, which is good. And here is a syringe covered, and you can see a syringe cover here, so that minimal dose is exposed to the operator. They'll put the syringe inside of a little lead cubby there, and then they're checking the lab to make sure that there's no spills or drips anywhere, to make sure that the area is safe. So, instrumentation. So there's gamma cameras, so it locates, measures, and amplifies gamma rays emitted from the patient. Can be single, dual, and most commonly triple. Triple heads are used in SPECT. And imaging methods, we have static, whole body, dynamic, SPECT, and combined SPECT and CT. So clinical nuclear medicine, we can do bone scans, scans of the central nervous system, endocrine, GI, GU, in vitro, in vivo. We can do studies for infection, respiratory. They can see if there's PEs. Sentinel lymph nodes, what we do, we inject an area around a cancer and see if it goes to the lymph nodes, like for breast cancer. Therapeutic nuclear medicine, which we can treat tumors with, and tumor imaging. So, clinical applications. With the bone, we study the skeletal system. With urinary, we look at the atomic and the function of the kidneys. Brain scans to evaluate for stroke, Alzheimer's, Parkinson's. We'll also do for brain death. So we'll inject and see if there's any activity within the brain. They require two different forms to verify brain death. One of them is using nuclear medicine, another is using MRI. So, clinical applications. So, with your gastrointestinal, we look at gastric emptying, hepatobiliary studies, the liver, spleen. Cardiac studies, we do myocardial perfusion, we do stress tests, imaging. Lung studies, we do ventilation and perfusion studies, but we'll look at them breathing and seeing how they're doing. Nuclear medicine, also here with the clinical, we do thyroid uptake with sodium iodine, taken orally, evaluates for hyperthyroid or hypothyroidism. The nuclear medicine technologist handles and assesses and administers radionuclides. The physician interprets interpretation of nuclear medicine procedures. The radiation safety officer reviews imaging protocols and dosimetry reports. The health physicist calibrates and maintains the equipment. So, the terminology, we have biologic half-life, cyclotron, decay, we have just half-life, isotope, scintillation, and technetium-99. So with SPECT, we have single photon emission computed tomography. So it provides improved imaging contrast, 3D dimensional information, and SPECT requires additional quality control procedures compared to just normal PET imaging. So A series of gamma camera images are required as the camera rotates around the patient. Typically 60 to 120 images will be obtained in 20 to 30 minutes. Image reconstruction is usually performed using a technique known as filtered back projection to produce a series of transaxial slices. Coronal and or sagittal slices can be computed from the transaxial slices. So here's a SPECT camera. This is a dual head, and it spins around the patient. So the table rises up and they slide in here, and here's the CT portion. So you can see the CT scan of the pelvis, and you can also see that the nuclear medicine scan, the SPECT, has been laid on top of it, so we can see exactly where the problems are, the hot spots. Okay, positron emission tomography uses a radioactive nuclei injected into the patient. Then they go under a gamma camera, and then they get scanned in CT, and it has the same fusion imaging as this here. So we use, typically this is a hybrid unit, I can tell by looking at it. So it has this in here is the gamma camera, and I think it's dual head as I recall. And then it has a CT scanner here in the front. So we stick them into the gamma camera for about 45 minutes to an hour, and then we scan them in CT, and then the software merges the two on top of each other. So here you can see a SPECT camera, a dual head, and you can see back in the back there is the CT portion. So here's a PET CT. This is what it looks like at an angle. You can see how big it is. Patients that have a hard time with MRI have a hard time with this scanner in addition. Here is a triple head scanner, so you can see what the 3 head looks like, typically used with SPECT, and you can see this scanner in the back. This is a thyroid or an individual, like one area uptake. So it has just the one area that's going to uptake over a small area. Instead of using a huge gamma camera, you can just use this little one. All right, so positron emission tomography is 3-dimensional. It's a topographic imaging technique that demonstrates biomechanical function of the body, organs, and tissues. It detects abnormal function, detects disease in early stages, and measures response to treatment. So if we're giving chemotherapy and radiation, it's going to tell us if it's working or not. So PET is a multidisciplinary technique with 4 processes. There's the scanner to perform the clinical examination, the cyclotron to produce the positron emitter, the standard chemistry system to create the chemical precursor, which will be further processed by the dedicated synthesis unit, and the tracer lab equipment to produce a tracer. So there's a lot to it. And PET scanning is very limited due to the high cost of setting up a PET in a department. So getting a hybrid scanner is very, very expensive. We're fortunate to have one at our outpatient center, but within the hospital we did not have one. So we had a gamma camera and we had a CT. They paid for the software licensing so that they can merge the two. All right, so clinical PET, we use it for oncology imaging. That's huge. Neurological imaging, that's coming up and coming, using it more and more for that, and cardiology. And kind of the idea here in CT, so we have 2 different hot spots that will overlay. So PET relies on this simulation detector of a pair annihilation. So emitted from the body. So this is actually talking about the annihilation of the reaction of the isotope. So here's CT, so it scans through the body, and here's CT here. So tracers are administered to the patient. Radiation emitted by the tissue is picked up by the gamma cameras. So positron emission from the nucleus combines with the electron, undergoes annihilation. So that's what they're talking about here, which is out of order. I apologize for that. So it undergoes annihilation, produces 0.51. That's interesting, right? Because it's 1.02, so it's 0.51 keV photons emitted 180 degrees from each other. Do you remember that? So it's 1.02 for annihilation, so that's a 0.51 keV. And common positron emission elements, so oxygen, nitrogen, carbon, and fluorine. So FDG measures glucose, and that's usually what they use for cancer. And then you have O-water, which does blood flow and perfusion, and ammonia, which is blood flow and perfusion also. Methylene is amino acid metabolism. So looking here, this is cyclotron with radiation shields. And you can see what it does is it accelerates subatomic particles, directs particles to non-radioactive targets, producing radionuclei. Tracers have a very short half-life of 120 seconds to 110 minutes, so very, very quick half-life there. And with positron emission tomography, clinical applications, so we assess and stage possible tumors. FDG is used to measure the glucose metabolism. Tumors demonstrate increased sugar, so FDG uptake. And we can manufacture the FDG, so it's not going anywhere. We're going to have that forever. The image demonstrates metabolic disease, including brain and bladder. So you can see in the spine all these little hot spots, lymph nodes. You see lymph nodes up in here. Yeah, so the brain is enhanced. This patient is in a bad way. So FDG does get excreted by the kidneys, so you will see an increase in the bladder. So I like that they said that there's cancer, excluding the bladder. That makes sense. So here, it's filtered by the kidneys and concentrates in the bladder. So never use a nuclear medicine restroom. Keep telling you guys that, never use nuclear medicine restroom. So clinical applications for cardiology, so we evaluate for coronary artery disease, and we use the ammonia given to evaluate heart perfusion, so sufficient blood flow to the heart tissue. FDG is given to evaluate glucose metabolism, measures whether normal function has returned following a treatment. So you can see that there's a dead spot here, and you can see that it's restored. All right, so neurology, we can look for epilepsy. We use the FDG given to localized seizure sites, so it'll show us here. So the arrow indicates increased glucose uptake. So there you go. And neurology, so brain mapping, localized area of brain function, including language, memory, vision, and movement, determine whether the lesion will affect key areas of the brain. So the blue arrow indicates language region of the brain, and the red arrow demonstrates AVM, so avascular malformation. Increase in cerebral blood flow during language activation exam. So you can see here the increased blood flow. So CNS tumor mapping, the methylene assesses amino acids, metabolism of the tumor. FDG grades tumor to determine activity of glucose metabolism. So we can evaluate for dementia using FDG. You can see column A is normal, B is mild dementia, and C is severe dementia. All right, so the PET-CT fusion technology, we actually had all the software. It's pretty cool. Acquire functional PET and anatomical CT images simultaneously. Two data sets can be displayed in a single merged image. So the hybrid scanners combine the PET and the CT like I showed you earlier. And co-registration of PET and CT demonstrates a medullary thyroid tumor. So you can see here is the CT, here is the PET, and the two merge. You can see exactly where that tumor is. And this is whole body scanning, and this is metastatic spread. That's the other patient. The brain, that's normal. Bladder, that's normal. The lymph nodes here, you can see lymph nodes. You can see the activity in the spine. That's not good, not good, not good. And this is a CT. This is common. We scan full head, top of the head, all the way down to the proximal 1/3 of the femurs, and they would do the same thing in PET. and you can see how we are able to merge. So this is just the PET scan, and then we merged them. You can see exactly where in the liver we have lesions. You can see the lesions here in the pelvic area, which aren't showing up here, which is interesting, but this is not normal. Okay, so that is your nuclear medicine PET SPECT lecture.